healthcare improvement research. And to to introduce you to this very important subject and to the speakers, I'm going to hand you over to Lisa Hinton. Lisa.
Thanks very much, Vivian. So welcome to the session on diversity and inclusion in healthcare improvement. This session will consider why the values of diversity and inclusion are so important to healthcare improvement research, and explore how healthcare improvement research can be inclusive, and crucially highlight some practical examples that you can use in your activities. Joining me for a discussion in around half an hour after their presentations will be Professor Natalie Darko from the Stephen Lawrence Centre at De Montfort University in Leicester, Dr. Tanvi Rai from the Nuffield Department of Primary Care Health Sciences in the University of Oxford, who I would like to draw your attention to is joining us from India today. And first up in the presentations, you'll be hearing from Roger Kline, who is based at the Middlesex University Business School, who's going to be talking to us about racism in the NHS workforce. So over to Roger, and look forward to joining you for a discussion in about half an hour. Thank you.
There's a growing awareness of the impact of discrimination on Black and minority ethnic patients. I'd like to argue that it's time we paid more attention to the impact of race discrimination against staff because of its impact on the care and safety of all patients, not just BME state patients. Racism against staff is a patient safety issue. We have a wealth of data demonstrating that BME staff in healthcare are disadvantaged in recruitment and career progression, in whether they are disciplined, bullied, harassed at work, and whether they're treated worse if they raise concerns or admit mistakes. Such treatment demoralizes staff, wastes talent, affects turnover, costs money, damages staff health. But crucially, it also undermines team working, incentivizes blame, not learning, and adversely impacts patient health and safety. So the NHS has, as I think we all know now, has an ethnicity gradient in which the more senior the post, the less likely we are to see Black and minority ethnic patients. It's 1.61 times more likely again this year that a white shortlisted candidate will be appointed compared to a Black and minority ethnic shortlisted candidate. And that must waste talent. Black and minority ethnic staff are more likely than white staff to be disciplined, more likely to be reported to their professional regulator by their employer, though interestingly, not by members of the public. BME staff are more likely to be bullied by managers and colleagues than white staff, and are 3 times more likely to report being discriminated against than their white colleagues are. And we saw the impact of these racialized patterns of employment during COVID. According to Public Health England, 90%, almost 90% of staff infection was due to occupational exposure, and BME staff were disproportionately impacted because they worked disproportionately in lower graded patient-facing roles. They had poorer access to appropriate PPE and fit. They were disproportionately redeployed to risky areas. They were more reluctant to raise concerns, and more of them were agency staff who may not have been reimbursed when self-isolating or had poor access to PPE. The risks to BME staff were compounded because instead of trusts organising workplace assessments in a timely manner to investigate and prevent the causes of infection as they're required, they prioritise individual risk assessments to safeguard individual staff rather than tackle root causes. We know that race discrimination makes staff ill. 2 decades ago, Nasru and Carlson found, and I'll quote if I may, over and above socioeconomic effects, both experience of racial harassment and perceptions of race discrimination make an independent contribution to health. For example, those who had been verbally harassed had a 50% greater odds of reporting fair or poor health compared with those who reported no harassment. And last year, the Public Health England report on disparities in the risk and outcomes of COVID-19 came to a similar conclusion. Overall, on race discrimination, I'm afraid we have largely looked the other way for far too long. And even when we have looked, it's been through the lens of compliance, not improvement. So what's this got to do with patient safety? Well, a decade ago, Dawson and West found, and I'll quote if I may, the experience of Black and minority ethnic staff is a good barometer of the climate of respect and care for all within the NHS. Put simply, if BME staff feel engaged, motivated, valued and part of a team with a sense of belonging, patients are more likely to be satisfied with the service they received. And similarly, West found that, quote, the staff survey item most consistently strongly linked to patient survey scores was discrimination, in particular discrimination on the basis of ethnic background. Black and minority ethnic staff are 21% of the NHS workforce, and an astonishing 28% reported being bullied and harassed by managers and staff last year, significantly more than white staff were. We know that the adverse impact of bullying has been well evidenced by Lever and others, and in turn impacts on performance, career progression, engagement, retention, and team effectiveness, as well as harming the safety and physical and mental well-being of staff. As American medic Lucian Leap put it, he described how a culture of disrespect in medicine is a threat to patient safety because, and I'll quote if I may, it inhibits collegiality and cooperation, essential to teamwork, cuts off communication, undermines morale, and inhibits compliance with an implementation of new practices. Staff who are bullied are less likely to admit mistakes, raise concerns, or work effectively in teams, all with consequences for patient care and safety. No surprise, therefore, when Robert Francis in 2015 found it was substantially more likely that BME staff who raised concerns would not be listened to, but would also be more likely to be victimised if they did raise concerns. Racism and bullying combine to undermine psychological safety at work. And this matters because, as Carter and colleagues demonstrated, inclusive and compassionate leadership helps create a psychologically safe workplace where staff are more likely to listen and support each other, with fewer errors, fewer staff injuries, less bullying of staff, reduced absenteeism, and certainly in hospitals, reduced patient mortality. As Amy Edmondson puts it, an inclusive work team recognises the deep human need to belong and the anxiety everyone may feel when speaking up or sharing ideas in front of others, for fear of saying something that may appear stupid or wrong. Inclusion may be regarded as the extent to which staff believe they're a valued member of the work group in which they receive fair and equitable treatment, and believe they're encouraged to contribute to the effectiveness of that group. Such workplaces and teams value the difference and uniqueness that staff bring and seek to bring a sense of belonging with equitable access to resources, opportunities and outcomes for all, regardless of demographic differences. As Lynn Shaw put it, I'll quote again if I may, inclusive organisations are more likely to be psychologically safe workplaces where staff feel confident in expressing their true selves, raising concerns and admitting mistakes without fear of being unfairly judged. But there's another benefit. When diverse representation is underpinned by inclusion, demographic diversity can improve team performance. The evidence for this is more nuanced than is sometimes presented, but it's convincing nevertheless. There's an evidence base that supports the proposition that effective leadership is diverse, inclusive, and compassionate. So, in summary, the NHS has within it racialized patterns of employment, which make staff ill, and these impact on organizational effectiveness and risk undermining patient care and safety. One senior Black and minority ethnic nurse put it to me about a year ago. She said, I've spent my entire I'm going to read it actually. I spent my entire career walking on eggshells, knowing that should I make a mistake or raise a concern, I will be held to a higher standard than my white colleagues. I have more than once joined teams where I'm not fully valued for the difference I bring or the insights I can share based on my ethnicity. Inevitably, this affects patient care and safety. Tackling racism is, first and foremost, a moral issue, but it's also a crucial part of improving the care and safety of patients and service users, whatever their ethnicity. So COVID-19 and Black Lives Matter have finally, I think, led to many NHS leaders asking how they can address this issue as a priority, no longer asking why. To do so, we have to stop leaving it to those adversely affected by discrimination to be the ones challenging it. We have to recognise that whilst overt racism is not normalised in the NHS, the patterns of bias, stereotypes, assumptions and behaviours that characterise systemic racism are well embedded and significantly damage patient care as well as healthcare staff. We can't afford to look the other way anymore.
Hello. So today I'm going to talk about diversity, inclusion in healthcare improvement research. I'll briefly focus on two key areas, which are why are values and diversity and inclusion so important in healthcare improvement, and how is healthcare improvement research, or how can it be inclusive? Specifically, I'll focus on equity healthcare improvement and then look at the problems that have arisen when equity is not embedded in research and practice. I'll then discuss how healthcare improvement research can be inclusive, with a focus on some practical examples that I have used within my research and in my other role previously at NIHR. So why are values of diversity and inclusion so important to healthcare improvement, and notably healthcare improvement research? When considering quality in healthcare improvement, we are aware that this focuses on the degree of excellence of something, notably how good or bad something it is. It is commonly understood as the degree to which it is safe, effective, and provides good, positive experience. It's also timely and equitable. However, to recognise the domains of quality in healthcare improvement and healthcare improvement research, we must recognise that equity and equitable care is embedded within quality. So when we consider this, we have to think about how equity is also important in our research. So to achieve safe, effective, efficient and patient-centred care, there is a requirement to shift beyond sameness and essentially equality, to recognise different groups, individuals, patient preferences, needs and values, and thus the need for different, targeted and tailored approaches in quality in healthcare improvement and healthcare research. Therefore, recognition of equity means providing care that doesn't vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. So what does this mean in the context of providing health improvement research, and why is it important? Equity implies that different groups, for example, ethnic minority groups or seldom heard or minoritized groups who have diverse needs and barriers, require different approaches just to achieve the same outcomes. So therefore, an important point to consider within our research is that one size approach to healthcare improvement and research does not fit all, and we must recognise that equity and diversity for inclusive in practice is important. So failings in the provision of equity and equity-focused research have been exposed in the COVID-19 pandemic. For example, Hershon et al. 2021 recently noted that inequalities or inequities in healthcare systems have been magnified for disadvantaged groups, particularly ethnic minority groups. Also, as the pandemic has evolved, the most striking finding has been the disproportionately high infection and mortality rates from people from minority ethnic groups, particularly in 2020 and moving into 2021. Unfortunately, research completed during this period has highlighted inequities, inequality and equity monitoring practices, notably the disaggregation of COVID-19 case and fatality data by ethnicity, and other social stratifiers have been missing. But much more needs to be done to ensure an equity-focused lens is adopted in research that captures how ill health is experienced across various groups, but also how wider factors and thus intersectionality of these social and cultural factors impact on healthcare and healthcare access. Research often focuses on a quite narrow equity lens and doesn't consider wider factors such as racism, migration history, religion, faith in particular. And all of these are fundamental factors in disease, health and healthcare access. In recognition of this, researchers have made calls for quality improvement healthcare research to embed equity more effectively. Also, Jensen et al. Have argued that there is an urgent need for equity-focused research, particularly for COVID-19 health improvement research. However, the important point to note is that equity is often forgotten or not explicitly measured or targeted in health improvement research and interventions. We must remember that the Equality Act, the public sector duty and health inequalities duty, as part of the Health and Social Care Act, encourage us to pay due regard to the need to reduce health inequalities of people in healthcare. But importantly, these acts require us to recognise diversity in patients' individual protected characteristics and their intersections. This approach must also be applied to healthcare improvement research and to address health inequalities. So what else do we need to consider that's important? Importantly, we must recognise that health inequalities could rise and misconceptions and misunderstandings of minority groups will continue. So I wanted to focus on three key areas. Firstly, that racial and ethnic health inequalities in health outcomes and access exist, and they will continue to rise. Secondly, we need to avoid misconceptions and misunderstandings of minority groups that currently exist. And thirdly, marginalisation and racism that exists will continue if we don't make changes. So if we look at recent research by Embrace from 2020 onwards, we have seen that maternal health outcomes and notably maternal mortality in ethnic minority groups or ethnic minority pregnant women admitted to hospital with COVID-19 was worse when compared to white majority ethnic groups. Specifically, Black and South Asian women were more likely to die in pregnancy than other ethnic groups. A recent report by the CQC on maternity services shows that women from Black and minority ethnic groups have differentiated experiences of healthcare and healthcare access and poorer experiences of care and face additional risks. If we fail to address and target these inequalities, then we have to consider that issues regarding patient safety will continue. And if we don't take an equity-focused approach and embed further evaluation measures, we can see failings will continue to occur. For example, the CQC recently found that maternity services and maternity voices partnerships across the UK were addressing some of these actions set out by the Chief Midwifery Officer to address inequities, but they were concerned that many cases or many actions taken had been interpreted quite narrowly, and also they were needed to make more services more equitable and safer rather than taking a generic approach to the recommendations. Secondly, values of diversity and inclusion are important because we can't misconceive or misunderstand ethnic minority groups and thus label them. It's become apparent in the last few years that minority groups, specifically ethnic minority groups, have been underrepresented in healthcare improvement research. We've seen this in clinical trial data for COVID-19, but also in wider health improvement in studies. However, it's commonly assumed that minority groups are underrepresented because they are hard to reach and inaccessible. However, within my own work within this area and wider work that I've been involved in, it shows that often minority groups are not necessarily hard to reach, but are seldom heard, and that the services and research practices don't reach them. Specifically, my own research with African Caribbean groups and South Asian women in community-based diabetes prevention programs showed that health provision and research are not culturally relevant, appropriate, or sensitive to their needs. For example, women within certain parts of the study were quoted as saying, "We are here, we are not hard to reach, you're just not reaching us or understanding us." So what is important to recognise is that healthcare and health improvement research and interventions can worsen inequities for those who are worse off or marginalised. When we misunderstand minority groups, they can also become stigmatised and blamed for a lack of engagement in services and their underuse, yet the evidence from patients is often ignored that sometimes illustrates prejudice, discrimination, distrust and the lack of equitable services. Thus, the term hard to reach is part of this stigmatisation process. Finally, diversity and inclusion are important in healthcare improvement research because of the rising incidence of racism and marginalisation that exists. Recent research in 2020 commissioned by the Joint Committee on Human Rights shows that over 60% of Black people in the UK do not believe that their health is as equally protected by the NHS when compared to white people in the UK. Experiences of racial bias and discrimination have been the cause for some of these perceptions. For example, research also shows that patients from ethnic minority groups are often experience racial stereotyping by healthcare professionals, in which they are perceived to be less compliant with treatment or blamed for poor health outcomes. Furthermore, patients from Black groups have reported experiences of their pain being underestimated and undertreated by healthcare professionals who held false beliefs that Black patients have a higher pain tolerance than other patients. Therefore, racial bias influenced pain treatment recommendations. Within my own research, I found similar findings amongst African Caribbean migrants who reported incidents in which healthcare professionals had misdiagnosed conditions because of similar racial stereotypes. Specifically, one Black male explained that a group of doctors had assumed he had high drug use, or high drug use was the reason for the patient requiring a hip replacement at a relatively young age. However, the patient was a former professional athlete and his injuries were due to this, but the stereotypical assumptions were still there amongst those doctors. So how can healthcare improvement research be inclusive? What can we actually do to make, what can we do practically to make change? So to improve, we need to consider and look at missing evidence and underrepresentation of minority groups. We need to think about what can be done and perhaps include mandatory training, for example, in ethnicity and reporting of ethnicity data, and make it a requirement within our research practice. Specifically, the inclusion of disaggregated data by ethnic groups and any other factors that impact on disparities in healthcare outcomes and healthcare access. We must avoid homogeneous ethnic codes and categories in which the diversity of ethnic groups are often lost. Broad categories such as Black can often miss racial groups within this type of category. These type of aggregated classifications limit the extent to which data can be compared, but can actually help us address health inequalities. Importantly, we must recognise that differences between groups, for example, variations by African Caribbean groups across islands or islands of origin, is really important, particularly for faith and a number of different practices that affect health outcomes. We must therefore recognise and acknowledge the cultural insensitivities in how and why some groups are aggregated within data. To address this, we can take further measures to include ethnic equality monitoring methods in our study design, recruitment, PPI and PPIE, and delivery of research. Notably, not only should we include equality impact assessments in the research process, we must then evaluate the effectiveness of these monitoring processes. This is often not included or considered. There are more steps to include equality monitoring, but less to look at the evaluation of its impact. So in accordance with the Equality Act, the public sector duty that I mentioned earlier, equality impacts assessments can be utilised to address this. Research by Isaacs et al. In 2016 showed that when ethnicity reporting in data sets has been mandatory in the US, particularly in diabetes, telehealth, random control trials, rates of participation of ethnic minority groups have been higher. But there is still much more that can be done to address issues of mistrust that's being experienced by minority groups because of racism and marginalisation. As mentioned earlier, mistrust has to be restored and recognised if over 60% of Black people in the UK do not believe that health is equally protected by the NHS. We therefore need to ensure our research practices are culturally aware, sensitive and culturally competent. I have previously been involved in designed training packages for researchers that helps improve equity awareness and understanding. Part of this is improving knowledge and use of the language and terminology, such as hard to reach, and moving stigmas and providing training on how we ask questions concerning race and ethnicity. Researchers can often design documentation and methods that are not accessible or culturally sensitive. Work by Ollie Williams and Josephine Oklo have done some great work in this area and drawn attention to the importance of co-production. And this is essential even before the researcher starts the thought process for research design. It can start as early as defining how an ethnic minority group or groups wanted to be defined or self-defined within a study. Within my own research, the inclusion of culturally sensitive spaces and activities are important to Pacific ethnic minority groups. For example, within my own research with Bangladeshi women, yoga was one of the key methods of engagement due to its cultural relevance and location with women-only spaces. So to briefly conclude on the points that I've made here today, I want to highlight that the one-size-fits-all approach to perhaps how we do healthcare improvement research doesn't always work. We must do more to embed equity into our research agenda and to provide regulatory frameworks to support improved practice. Thank you very much for listening.
Hello, my name is Tanvi Rai and I'm a senior researcher based at the University of Oxford. And today I'm going to be talking about mainstreaming diversity and some strategies for doing more inclusive research. And I've put diversity in inverted commas because I really don't like the word, because it's come to mean something annoying, like a tedious add-on and quite separate to the fundamental project of doing robust and high quality medical research, which I think is a problem. And in the next few slides, I'll explain what I mean. This is just to acknowledge the funders and the participants in the studies that I've been talking about. So we have a problem of homogeneous samples. Many large research studies have this problem, and what they end up doing is when they write their results, they have a section in the discussion which goes something like this. Most of the participants in the study were white and few had low socioeconomic status, meaning more research is needed to see if the findings hold in other groups. And like the second one, where our patients were predominantly white, middle-class men with low levels of social deprivation. And a bit later down, it says, issues such as lack of support, financial worries and difficulties with transport may be less problematic for our patients in comparison to patients from socially deprived areas. And that's where it ends. You know, people write this in their paper and then they move on to the next study. However, if there is a complaint about it, or if there is a bit more money left in the pot, there might be a secondary bit of research that focuses on that particular seldom heard group of people who had been excluded before, but it will be published in a lower impact journal, and the narrative will foreground, you know, the cultural or social identity more than the disease experience or the intervention. So I'm going to talk about two studies that I've been involved with. One of them was a study called the BP Together, and this was a pre-trial study. So we were developing an intervention which would lead to a large multi-center trial. It was a qualitative study where we had a prototype intervention and we were optimizing it and developing it for this particular group. So the population group we were looking at were people who've had a stroke or a mini stroke, which is a TIA, because this group is at risk of having a subsequent stroke. Once you've had a stroke, you could have more. And one of the best ways to reduce this risk is to have your blood pressure nice and low. However, the care for people who've had a stroke at the moment is very inconsistent. Some people see their GPs very often, some people don't see them for years. And so the idea was that this system would allow people to take their blood pressure at home every month over a week, send their readings to their GP, and it was very interactive. It would acknowledge when readings were sent, it would tell them if they're doing okay, it would tell them if they needed a change in medication. And my role at this point was as a field researcher interviewing stroke patients and GPs about what they thought about the intervention. So given my background as in public health and social epidemiology, my first question when I started the job was, who gets stroke in the UK? Because obviously I thought we should be identifying and targeting the group that is most likely to benefit from this intervention, the group that's most badly affected. And so I found out that it's a very big killer. There are more than 100,000 strokes every year. Men get it at slightly younger ages than women, but women get it too, so we have to include them. And then I looked at ethnicity and deprivation. And what I found was that Black people were twice as more likely to have a stroke than white people. Black and South Asian people were likely to have it at younger ages. And actually people from deprived areas had more severe strokes. But very damningly, in the past 20 years in London, there's been a 40% decrease in stroke incidence for white people, but not for Black people. And so I thought the case was clear. So we set about recruitment, and initially I followed what was the kind of normal procedure for recruitment for studies that are based in primary care. We sent out expressions of interest to practices in the local area. Participating practices agreed to run searches to identify who's eligible, and then they send out letters that we produce on university headed paper with the patient information sheet and reply slip for people to send back if they wanted to take part. But we had to stop at about 4 practices because the response was overwhelming. So many people wanted to participate, but once we started looking at who they were, we realized this was a very narrow demographic. It was mostly retired, elderly, middle-class people who were white. And this bias was right from the top. GP practices that were located in high deprivation areas and those serving a more ethnically diverse population were just not research active. They didn't have the capacity. Even when contacted directly by me, they said that they were too overwhelmed by the complexity of their patient load to be able to take part in research. And so with the blessing of the research team and the PI, I set out to be a bit more creative in how we recruit. I went off, made contact with local imams and pastors, went to church, went to mosques, went to prayer meetings. I dressed appropriately so that, to signal respect. And trust. I told people about the research. I told people about the lack of representation and how minoritized groups are disproportionately affected by it, by stroke. And actually people were really interested, and there was lots of interest, except that they could not participate unless they'd had a stroke. Had the study been about hypertension, probably we wouldn't have any trouble getting bigger numbers. Likewise, I also recruited from other areas of deprivation via support groups and talking to the funders about helping us recruit. And in doing so, as the statistics told us, we found a lot more disability, people getting strokes at younger ages, and different kinds of organization of care and so on. But what was really interesting was how they viewed me. And in my more than 20 years of being in the UK, I've come to realize that white British people feel really uncomfortable talking about race and class. And perhaps because I am an ethnic minority immigrant, I found it easier to talk about these things, without feeling too self-conscious. But I think what was more effective was that I put the issues of health inequalities based on race and class on the table from the outset. And people really appreciated that. And then, of course, going face to face really helps. And the fact that I was going to people rather than expecting them to come to us. But then the pandemic happened, which obviously changed everything. A lot of changes happened in the health research world, but for me, the two main things were that the stroke trial stopped because the funders decided there wasn't enough difference between the control group and the intervention group in the changes that happened because of the pandemic. So that stopped. But also there was lots more research on COVID. And so like everybody else, I also started on a study, working on a study that was about COVID. So this is the diverse experiences of COVID-19 study. Among, apart from the outputs that would be academic papers, one of the main outputs is going to be a section on the online public-facing platform called healthtalk.org, which, if you don't know, is a site where there's more than 120 different topics about health experiences or health conditions, where we present clips of interviews of people talking about their experiences, plus links to clinical information. And it's used as a source of support and information for the public, but also for clinical training. For this study, we wanted people to talk not just about their experience of illness, but also the experience of the pandemic in terms of how it affected their finances, their employment, their mental health, their household situation, how practical it was for them to follow the guidance and so on. And unlike the stroke study, where we realized later that our research, that our normal methods were exclusionary, for this one, from the outset, we made it part of the main plan to include people who were disproportionately affected. And as we know, these were initially, we thought people who were older and frail. Later, it turned out to be all adults, people with comorbidities, but then healthy people started getting sick. But importantly, it was people who had high exposure jobs, who were public facing, people who didn't have sick pay, they were on 0-hour contracts, they weren't able to work at home, people who lived in multi-generational households, people who had no recourse to public funds. And given the intersections of multiple disadvantage in the UK and how they manifest, this meant that racially minoritized groups were most badly affected. And so, while previously we could do a lot of the recruitment and trust building face-to-face, now we had to do it remotely. We couldn't use GP practices because nobody was seeing their GP. And also we had to use lots of other networks. So like this slide lists, we use lots of different places to recruit. We obviously had to make contact through emails, through phone calls, lots of detective work, working out, where different community groups are based and what do they do and who do they serve. We gave lots of time for trust building. You need to give enough time for people to be first suspicious of you, and then you talk through it, and then finally they come on board. Given that we weren't going to just talk to people who were middle class with high-speed internet, we built in capacity to provide data packages and a tablet that we could lend them for the interview. And given that we were going to put this on a public-facing website, we wanted to allow people to have a place to express what they have been through, but in an anonymous way if they needed to, so they could just do telephone interviews or text only. So, like I said, lots of our social and professional networks. We did lots of reciprocal favors, writing letters for them in return for them recruiting for us, and so on. Long conversations on the phone. We snowballed through people who had already taken part. We also had ad hoc researchers who had skills in other languages, and so that we didn't exclude people who didn't feel comfortable in English. And lots of recruitment at, in dinner parties, electricians who come to the house, the kids with the kids at the playground, and so on. And so, how do we involve underrepresented people in research? So firstly, I would say, look at the data, who gets the disease, find out where they are, and just get out there, which is obviously difficult in the pandemic, but there are still ways of doing it. But also it's important to look at the research methods and processes that we're using and the tools that we're using and the team that's doing the research. Think about the documentation. Are they, given the way that they look with the very sort of severe language and the logos at the top, is it likely to be a bit frightening? Will it look a little bit too much like more hostile official documentation that people might be used to? And if so, then we need to compensate for this by having a lot more time to explain what we're really about. The short timelines on a lot of studies means that everything is routinized, but then also that has an impact on whether we are going to be in a position to contextualize what we find, even when we recruit people from groups that aren't normally represented in research. And also each of us is limited by our own perspectives. And it's important to see who gets to tell the story. So look at the team, how diverse is the team in terms of what they'll be able to look out for and anticipate as missing in the research. Otherwise, we end up in this sort of situation. Good intentions are not enough. It's too easy to say we tried, it didn't work, and to move on then. It needs to be costed for and accounted for and built into plans from the beginning. Then I think this is my last slide. I wanted to say also, I've talked quite a lot about recruitment because the time is short, but actually inclusion is not enough. There is a risk that if you make lots of effort to include people, but then not enough effort to listen to them, you'll end up with representation without a voice. People who are routinely excluded will find it harder to get on board. At the stage of writing your proposal, think about, can you really wait? Will you really listen? Without being backed up by institutional support and machinery, there is a risk that you invite people to take part, but then you may expose them or exploit vulnerable people. The question to ask is, do you really care about this? Health improvement research cannot be apolitical. We need to think about whether this, how is health improvement research situated within the very real and present world of hostile environment, austerity, the PREVENT program, Islamophobia, anti-Blackness, and anti-refugee rhetoric that people live with every single day. And also with historic cruelty and unethical practices within the academy. So I'd like to end just to say that the academy needs to make its position, its political position, its ideological position much more explicit and visible to make research more inclusive. And that's it. Thank you very much for listening.
Thank you all three for a set of really powerful and thought-provoking talks. I'm now joined by Roger, Tanvi and Natalie for a discussion for the next 20 minutes. We've got a few questions in the chat already, but do please put some more in if you've got a question you'd want to ask. But I'm going to take the liberty of asking a couple of questions first. Roger, your talk, just to bring us back to the issues that you raised, really focused on the challenge that the NHS has racialised patterns of employment and made a call for us to really think about tackling racism not only as a moral issue, which of course it is, but also as an integral part of providing safe and effective care to patients. And then Natalie and Tanvi, you've really focused on making the case for tackling health inequalities in the way that we approach research and really doubling down on this problem that we have. I really like that phrase in your talk, Tanvi, about the problem we have with homogeneous samples. I wanted to ask a question just following on from those talks about how we do things better. And one of the issues that was raised in both all talks really of who carries the can and takes responsibility for this. Roger, I wonder if you could just start by talking us, we can't expect that the people who are experiencing racism should be the people that are charged with tackling these issues.
Well, we all have a responsibility, particularly white staff, and particularly those who have taken on board levels of responsibility, most obviously the board, but all the way down to frontline managers. And I think there's a few very quick points that I always say. We have to acknowledge the problem. We have to work harder at talking about it. we find it really hard what David Thomas calls protective hesitancy. We have to emphasize that tackling racism against staff is about improvement as much as it is about compliance. We have to have leaders at every level who model the behaviors and decision-making that they expect of others, put ourselves in other people's shoes, making it safe for people to raise concerns, because it's often not at the moment, get a very defensive response. As an example, we must never again do what NHS England did at the start of the pandemic and, believe it or not, suspend the collection of workforce race equality data on the grounds it wasn't a priority. We have to accept that most discrimination in the NHS is not blatant in your face discrimination, but it's subtle, it's cumulatively toxic, it's often hard to prove, but that means we have to tackle racism, not just racists. We have to develop the confidence to challenge poor behaviors in the moment when they happen, not provide sympathy afterwards. And final thing, and this is especially what I say to boards. Boards are much more asking about how they tackle this rather than why they should prioritize it. But that makes it crucial that we adopt strategies that have some evidence underpinning them rather than are based upon good intentions. And that's quite a big challenge, but I have to say that there are numbers of trusts now trying to become anti-racist, not non-racist. So I'm a bit of an optimist.
Thank you, Roger. Tanvi, I wanted to bring you in here and ask you to reflect on how you think we can work to make this all of our problems, not just a subset of our society's problems.
Lisa, can you hear me?
Yeah.
Okay. Yes, well, when I did that bit of work for the stroke trial, I actually went along and kind of, the timelines with the trial meant that I kind of got on with it, and I had I was given enough autonomy to go off and do it. And then the real discussions about what it is that happened and took place and what we learned from it came afterwards, when actually in the wake of the kind of BLM protests and the great sort of national awakening that followed about, what, some people have known for a long, long time, but other people haven't. It's been this kind of very peculiar, unbalanced situation. But anyway, that kind of created conversations. We started having conversations within the team and within sort of wider the department as well about what happened and why is it that we keep making the same mistake over and over again. And although it was really a little bit uncomfortable to have to, like you say, always kind of be the one person in the room who feels like they have to kind of go slowly over what is wrong and why it feels wrong, and why the tools that we use and the way in which we do research can actually be exclusionary. It kind of felt like a sort of a necessary step to kind of then get people to a point to be able to, people who may not, have known it not because of any malice, but because they haven't really, paid attention or it hasn't affected them. And so it was kind of, it did lead to conversations that then I no longer had to lead, not just in the research group, but also in the department. And I mean, it was quite, it was stressful and uncomfortable, but then it was also quite positive. The main thing would be to keep the momentum going. And I share a tiny bit of pessimism about the possibility that this was this year and last year, and will we continue doing? Will the wheels keep turning now?
So we need to keep up the momentum. Yeah. This discussion leads me on to a question that we've got in the chat from Mary Dixon Woods, who asks, I'm interested in how the bureaucracy of research governance may, in brackets, ironically, get in the way of using methods most likely to be inclusive. Natalie, I wondered if you could reflect on that, please.
Yeah, I think it's challenging with research governance because there's so many things that we need to follow and do. But I think the argument is that don't we need to change research governance I think we need to do a lot more within our own institutions and practices to change some of that information, particularly in relation to equality monitoring data, equality impact assessments, how they're utilised in research, and maybe we need to make challenges ourselves to look at the governance processes. But I think there are a number of challenges, and I think there was also a question in the chat related to ethics and ethical processes, which I think ties into this. And I think Tanvi mentioned it as well. We can do a lot more to change the practices around ethics and governance as well, in terms of how we build our relationships with participants that are perhaps minoritized or seldom heard, but improve the transparency processes, and also what we're doing with the data, and in the sense that there's more transparency and ownership of what happens with the data, what they're involved in, what that ongoing relationship is. But also one of the key things that comes back, particularly at the moment, is, and amongst minority groups, is that we're over-researched at the moment, but nothing happens after that. So minority groups are currently being approached to take part in research or ask for comments or be part of PPI groups, but then nothing happens, or the outcomes are implemented but they're not aware of it, and then they're approached again, and then there's this kind of short-termism that happens. And if we could build that into the governance processes, but also into the ethical processes of what happens next, I think that's the important part that we need to develop. And I really think, picking up again on the points raised by Roger and Tanvi, is that there's a lot of distrust and misconception amongst ethnic minority groups against many organisations, bureaucracies, governance, etc. We need to make changes to address and build that trust. So if we can change the governance patterns and procedures that we take and the ethical processes, we can start to build trust and kind of work against the distrust that exists and move beyond the stigmas that are currently happening. So that would be my complicated answer.
Yeah, no, it's a great answer. And I just, before I move on to another question, I just wanted to pick up on the approach that you mentioned in your talk that is taken in the US with the research funded by the CDC that mandates inclusive recruitment for big trials. Do you think that would be an idea to introduce here?
It's very difficult. There's lots of people for and against equality standard or mandatory equality monitoring. Some people feel that it would make change and some people are against it. I think it's entirely dependent, I think, on the research study and the trial in particular and the group. I think having equality impact assessments within the process. So for example, if you're in a location that's difficult, or there's a lower percentage of a particular group with a particular protected characteristic, evidencing that you've addressed that, and then having mandatory equality measures within that may be difficult. So I think in a way it would be nice to see what the audience thinks on whether it would actually work, but I think there are fors and there are against. In certain institutions and other fields beyond health, it does work, and also there are problems when it has been implemented and it hasn't made much change. So I think it's dependent on the research study, the researchers, the geographical location, the protected characteristics, and all the other factors around that. So I think I wouldn't say yes at this point, but I think we do need to take steps to get us closer towards it.
Thank you. I'm going to move on to another question in the chat, which is a question of geography. So John Brown asks, would be interesting to hear views on inequities driven by geography. Are we hearing enough from people outside of the big metropolitan areas? For example, marginalised coastal communities often have the worst outcomes. Are we hearing enough from them? Tanvi, I'll come to you first.
No, not enough is the short answer to that question. But organizations like the NIHR have, it has come to their attention, and they have started doing these heat maps, for example, where they look at the prevalence of a disease, and they look at where the research is taking place, and there is not enough overlap between that. And so now I've certainly come across some kind of funding things where they're specifically highlighting those heat maps at the beginning and saying this is where the lack of overlap is. So we want people who can either, you know, collaborate or with people based in those more, you know, less kind of golden triangle areas, more, you know, who have been neglected. So there is a bit more attention as you know, and you know, it obviously needs some big institutional structural machinery to shift for that to be made possible, because obviously people have over time, and we've written a paper about this, how you know, convenience and knowing colleagues that you've worked with before means that you kind of keep doing research in the same way as you've done for the past 25 years, because you know the networks and that's who you go to. So all that needs to shift to facilitate more geographic representation.
Thank you, Tanvi. Right, another question from the chat, which I'm going to direct to Roger first. So Samar Bermuni was interested in Dr. Rai's comment that diversity of research teams is also important. What are the panel's thoughts on supporting workforce development to achieve this? Now, Roger, I know you think a lot about workforce. Would you like to take that one first?
So the NHS has a lot to learn about how it does workforce development. I mean, we don't have a proper workforce plan. Most trusts do not have proper talent management plans. Much of the workforce progression that happens is done via a tap on the shoulder. But alongside that, there are organizations doing some really innovative work. So I won't name the trusts so as not to embarrass them, but one big trust in the middle of the country has a fantastic program where they've reached out to probation services, care homes, migrant communities, and have brought in and have developed a pipeline of people who've become very skilled and very committed from completely marginalized backgrounds. But I have to say that's not yet the norm. So we do have examples of trusts really working very effectively around some of these issues, with the board taking on a responsibility of accountability and using the same methods that we would on that a medical director would around the standards of work of doctors to insert accountability and de-bias processes in terms of being able to know what's happening. But I think my last comment would be the approach, the paradigm that we've used in workforce development and in addressing organizational culture has been a kind of reliance on policies, procedures, and training. It is a completely unevidenced approach. In fact, the evidence is quite clear that relying on de-biasing people and policies and procedures will never bring about the changes we want. There are much better ways of doing that. And there's work going on, including by myself, to demonstrate better ways of doing things.
Thank you, Roger. And I wonder if Natalie or Tanvi, you'd like to comment on the importance of tackling the research workforce and whether we need to do more to diversify and non-homogenize that. Natalie first.
I think yes, we do need to do that, but I also think it's also important to help anyone improve their understanding, but also listen more to minorities, seldom heard, underrepresented groups. I think it's more, yes, we do need to diversify and make kind of diverse, I know Tanvi doesn't like the word diversity, but more diverse representation in research teams, but also I think it's about listening and engaging underrepresented groups from the outset and keeping that relationship ongoing. So there's a process of learning, and also definitely more improvement on moving beyond traditional tick box, cultural competency, equality training for researchers, much more inclusive, informed research that widens all of our knowledge so that we can all learn from each other, and also much more than just the standard protected characteristic areas in a way, but also those intersections and intersectionalities within them. And I think picking up from the point about geographical being geographically rural, recognizing that as a factor that impacts on health is important, and also how that intersects with other things such as religion, race, disability, etc. Improving that understanding and how to have better relationships with underserved groups, I think, is important.
Fantastic. Tanvi, we've got 30 seconds left. I don't know if you have kind of 2 or 3 quick thoughts that you want to share with us before we wrap up this fantastic discussion.
Just to say that, well, I mean, the thing is, I don't not like the word diversity, but I think that what's missing in these words like diversity, inclusion, equality it sounds really passive. And I feel like racism and exclusion is a political thing. And we cannot, in the academy, in organizations that serve people for health and health improvement, this is the time to show our true colors, and we have to be anti-racist. And that is a very active thing to do. It's not just, oh, let's include some more people. It's actually very active, being anti-racist is what we need, adopting a political position that makes that really clear, so that people are not cynical about it. That's what we need to do to kind of shift things truly.
Thank you, Tanvi. Thank you all for the brilliant presentations and this really fantastic discussion. I think we are all energized to keep working and not be passive. I'm now going to hand back to Vivian, who's going to introduce our unbelievably final session of the day.